let me follow up on that point, because I think one of the really, challenging things is what's the opportune time to check for these genetic alterations? And it depends a little bit on access to tissue, right? And if it's an old archival prostatectomy from 10 years ago, how relevant is that? Whether or not they have soft tissue to biopsying bone. If it's a blood-based, assay, what's the optimal time for that in terms of having enough tumor burden to find these? And to your point, Eleni, being able to do it before you've exposed them to drugs that are unlikely to benefit them. So before chemotherapy. So where do you see this? And can you give me sort of some broad strokes on your approach for genetic testing in castrate-resistant prostate cancer? I'll open it up, but I'm looking at you, Eleni, because you're the biggest picture on the screen for me.
We can't tell who you're looking at, Dan.
Oh, you can't tell. Okay.
So, but you're talking to people that, including yourself, we're like all about doing biopsies every nanosecond. So it's unfair. You have to go for the archival tissue. I mean, we've got some data now showing clearly that at least if you find the DDR there, it's going to be there, right? We have proof of it. But ideally, you'd want to go for real time and a liquid biopsy. Now, I'll tell you, I've got the experience recently of a patient of mine a year and a half ago coding while having one of those biopsies. And I'm like, I'm not touching this guy again. I'm not doing any biopsies. He's alive as well. But all of a sudden, his disease has gone crazy on us, and he's having PSA low with progressive disease. So I did a liquid one, the one that's commercially available, and I got an MSI high just like that. I mean, 2% chance of getting it. Hello, he just started today, Pembro. So, I mean, you have to go for whatever you can get right now that is at least validated in a way to be CLIA certified or what have you. But archival tissue, at least for practices out there, is something easy to go for. We have to be practical.
Any thoughts on that, Tanya? Do you any other things to add there?
Not really. I mean, I agree. I'm a fan of a metastatic biopsy. Bone doesn't always perform, so soft tissue when available. But the reality is we use a lot of archival tissue and we use liquid biopsy. But the timing, I think, is a really interesting question. If you get a ctDNA assay that's negative, did you do it at the wrong time, and when should you repeat it? I think that's a real nuts and bolts question that we have to try to answer.
Yeah. I like to do it while patients are progressing. I think that if there's one lesson out there is once I've started a therapy and they show some response, even if they've got tumor burden, I'm less likely to pick that up. So think about it as your patients are progressing, as you're seeing scans show progression, symptom progression, as Tanya mentioned earlier. These are all opportune times to think about that before you make that next treatment. You can still go ahead with that next treatment, but check it, because you find things like Eleni pointed out, and that's a lottery ticket for that patient.
Well, it's also, there was a really nice oral presentation from Eric Small at UCSF where they looked at metastatic biopsies and they did genomic sequencing of methylation. They did, methylation sequencing and methylation patterns, and essentially identified what looks like a almost new state of prostate cancer. That might be a little bit of an exaggeration, but it's something that was distinct from standard adenocarcinoma, distinct from neuroendocrine, and had a very different outcome. Actually, I think a better outcome. And so it just speaks to, again, the more we look, the more we will see. And doing the biopsies, especially for those of us in the academic centers, with all the tools that can be presented to us, is really very valuable. But I would encourage, even when we're not doing things like methylation and genomic sequencing, that even understanding if a patient has transitioned into a neuroendocrine type is actually very reasonable. And that is not rare. That may be, in some estimates, 25 to 35% of the patients who are experiencing progression on abiraterone and enzalutamide may actually have neuroendocrine disease. And that should be brought out, and we should study that, and we should be treating that differently.
And sometimes it's obvious, like liver mets or lytic bone metastases, and sometimes it's not. I've seen it in lymph node disease. I've seen it in regular blastic bone disease. So doing the biopsy, you used your cues like the low PSA with visible progression. But I do think those biopsies are very informative.
In fact, the data, Tanya, suggests that, it's not any more common in liver or less common in lymph node. It's a kind of everywhere. And one of the limiting factors is how good we are at doing the biopsies and the pathologist who looks at them, right? So you talk about a field effect. This is an effect that our whole field has to learn to adopt in terms of even the interventional radiologists who do these biopsies, need to become expert at it. And our pathologists, give us varying degrees of ability perhaps to detect neuroendocrine disease.
I want to bring up a couple of things. One last question, and actually Tanya brought this up offline a little bit earlier, and I wanted to put it on here and get everyone's thoughts on this because, as we use more of these, life-prolonging therapies in the castrate-sensitive disease state, the biology that emerges in the castrate-resistant prostate cancer is different. And a number of the patients in the CARD study had treatment in the metastatic hormone-sensitive or castrate-sensitive state, and then progressed in castrate-resistant. So recognizing that our therapeutic history doesn't start at castrate-resistant; it starts earlier. That those treatments have implications on how we manage patients, I think is a really critical aspect of this kind of sequence biology and thinking about this and when we do these testing. So one other point for me is that when I have a patient, that I'm treating in the castrate-sensitive metastatic setting, I like to biopsy them if I can as they become castrate-resistant, because that biology may be very different than had they come through, say, a non-metastatic castrate-resistant pathway.